can simulate therapeutic, neurosurological, endocrinological, gynecological, psychiatric, and other diseases. Skin problems can be not just an independent disease, but often they are external manifestations of diseases of internal organs and systems. From practice, we dermatologists know that a significant part of patients with skin problems seek medical help not from a dermatovenerologist, but to doctors of other specialties. For example, patients with microbial eczema go to a surgeon. With syphilis, they can go to the surgeon because first symptoms of syphilis are erosion or ulcer of the gland penis, for example, and growing lymphadenitis. These patients go to the gynecologist, to the oncologist, because all people know about cancer, and now that he see ulcer or ulcer, it's maybe cancer. This patient can go to the otorhinolaryngologist because maybe atypical heart chakra or specific inflammation on one tonsil, shunt amygdalitis. This patient can go to the infectious diseases specialists because symptoms of secondary syphilis are skin rashes. With toxicoderma, patients will also turn to an infectious disease specialist or allergist. For example, among patients of a general practitioner, 40% of patients have skin diseases. Therefore, knowledge of the basics of dermatovenerology for a doctor of any specialty is a big plus in his practice. Expanding the horizons of dermatology makes it easier for general practitioners to diagnose and treat them. Even without being able to make a diagnosis, the doctor can assess the severity of skin changes, the need for consultation or emergency specialized care. The main tool of a dermatologist is his eyes, and none of the most advanced technologies can yet replace visual diagnostics. To suggest, to make a correct diagnosis or to outline the range of diseases with which a differential research should be carried out. All this a dermatologist does only on the basis of a patient's examination. Diagnostic based on the history and physical examination of the patient has not lost its importance in our 21st century of high technology. And this is true for absolutely all medical specialties. Again, the main tool for examining the skin is the eyes of a dermatologist. It should be noted that already after the first examination of the patient, the dermatologist has a definite opinion about the nature of the disease. Since with each dermatologist, there are strictly different morphological elements with their characteristic localization. The basis of dermatological diagnosis was and remains the examination not only of the examination of the skin and mucous membrane, but also of the derivatives of the skin, hair and nails, sweat and sebaceous glands. In dermatology, it plays the same role as computed tomography in the diagnosis of brain tumors. The dermatologist's ABC or alphabet is knowledge of the morphological elements of skin rash, the primary elements that appear on the skin and mucous membranes for one reason or another, and the secondary are ones that are formed as a result of the evolution or decomposition of the primary elements. It is impossible to offer to read a book to a person who doesn't know the letters. So it is impossible to require a doctor or student to diagnose a particular skin condition disease if it doesn't understand the components that form a rash. Thus, the morphological elements are kind of the dermatological alphabet. When assessing the affected skin, first of all, the morphology is established rashes, analyze their prevalence or limitation, localization, symmetry, asymmetry, or linearity, for example, by the course of a nerve or vessel. Features or mutual location, scattered root, with any type of location of changes of the skin should be carefully analysis of morphological elements of the skin rash. First the primary ones, then the secondary ones. The primary elements is the immediate first result of the pathological process in the skin. Secondary elements, those that develop from primary elements due to their spontaneous evolution or arise as a result of treatment patients. When examining dermatological patients, 23 can be identified morphological elements, of which 8 are classified as primary precipitation elements: spots, papules, tuber, nodule, infiltrative elements, exudative, vesicle, vulva, pustule, and wheel. And spots, papule, tuber, nodule, vesicles, vulva, pustule, and wheel. Sometimes we use the biopsy methods in the diagnosis of atypical dermatosis, or microscopic and cultural diagnostic methods, genotyping methods, PCR test, for example, in order to confirm our assumptions about a bacterial, fungal, viral, or other infection. We can also do serological tests and some other special diagnostic tests. But still, the main methods of making a diagnosis in dermatology is the correct interpretation of the red that we see on the skin and visible mucous membranes of the patient. Changes in the nail plate and the nature of hair image are also of great diagnostic value when making diagnosis in dermatology. To make a correct diagnosis, the doctor must know what he is looking for, or what he wants to see. When we consider a rash on the body of our patient, the first thing we have to determine is which primary elements of the skin rash represent the disease. Skin diseases can be characterized by a rash of uniform elements over the entire surface of the body, such as urticaria, for example, allergic disease, for which only wheals are typical. Wheals. There may be many of these wheals, but however, the primary elements is one and only one, which is a wheel. And in this case, we say that dermatosis is represented by a monomorphic rash, a wheals rash only. Another thing is an example of polymorphism, when at the same time on the patient's skin we see several types of primary elements at once. For example, spots, papules, vesicles. This means that the first thing determine the nature of the lesion. Further, in order to make a skin diagnosis, it is important to know what is the typical color of the primary morphological evidence. For example, the color of lesion plants papules cannot be confused with any other papule because these papules have a purple red hue. The size of the morphological elements of the lesion is also important. So, for psoriasis, the typical size of papules is 2 mm diameter, and with lesion rubor plums, the papules are small, 1 mm. The next one. What do we see on the surface of a skin rash element? The surface of the spot or papules is smooth, or there are scales. These scales are easily removed, such as with cibulia, for example, or their removal is accompanied by sharp soreness because they have a spine of the inner surface that penetrates deep into the skin due to the developing process of follicular hyperkeratosis, such as, for example, in chronic cutaneous lupus, skin fold of lupus. And the patient will scream loudly if you try to scrape off this scale. Other rashes prone to merging with each other. For example, psoriatic papules merging into plaques, and the papules characteristic of secondary fresh syphilis never merge with each other. And this helps us to differentiate it. Psoriasiform syphilis, such as papule syphilitic eruptions, from psoriasis. These two diseases can be very similar to one another. The practicing physician should never forget that syphilis is the monkey of all diseases and a great simulator. And in order to avoid diagnostic errors, one must keep these tools in mind. After all, we make diagnostic mistakes when we aren't alert to this or that disease. The next important point. What are the places of the favorite localization of the rash? That is, on which parts of the body does the rash appear more often? On which places of the body did the rash begin to appear initially? For example, psoriasis is characterized by edema to the extensor surface of the upper and lower extremities and scalp. And the secondary period of syphilis begins with rashes on the lateral surface of the trunk. When you start to study a new unknown skin disease for you, you should understand what is affected in this disease. Only the skin, or the skin and mucous membranes, because some dermatoses begin previously with the appearance of the first signs of the disease on the mucous membranes. For example, true or acanthalytic papules, or lesion rubor plums, with manifestations of which on the mucous membranes of the genital organs in women and the oral mucosa in men and women are found by gynecologists and stomatologists. Pay attention to where the nails and hair are involved in the pathological process. And if they are affected, then how? Is the hair breaking off or falling out? If hair fall out, what remains at the site of their loss? What is the nature of the skin? It can resemble a billiard ball and have a smooth, shiny surface with gaping. That is preserved hair follicles, which means that the hair will still grow. Or a persistent cicatrical atrophy, scar atrophy may develop at the site of lost hair, such as in Reed-Lasser syndrome. What is it, Reed-Lasser syndrome? It's manifestation of leaching liver glands. And hair will never appear in this place because atrophy of hair follicles. Hair can break. And this is typical for fungal infections, trichophytosis. These are microsporidia and trichophytosis. But these two diseases are distinguished by a different level of broken hair. For example, 5-6 mm microsporidia and 2-3 mm or only black dots remain from the hair. Trichophytosis or chronic trichophytosis. Nails can thicken, come from the green edge, as with fungal infections, or nails can grow very poorly and slowly, atrophy, such as in hypothyroidism, disease of the hypothyroidism or have a tin-like groove on its surface, which is typical of psoriasis. For diagnosis, it is important that the rash is located symmetrically or asymmetrically. Symmetrical arrangement of morphological elements of skin rash papules is typical for psoriasis. And unilateral lesion is characteristic of herpes zoster viral disease. The basis of diagnosis in the patient's complaints, which we call subjective symptoms. Why are they subjective? Because the patient may sometimes feel that he feels itching or burning in the skin, which in fact is not there. Particularly sensitive persons, sometimes it is enough to say the word head lice, for example, pediculosis, or scabies, in order for them to have a feeling of itching. This incidentally also applies to young doctors. Objective symptoms. Objective symptoms are those that the doctor saw when examining the patient. The objective symptoms are primary and secondary morphological elements of skin rash. Subjective symptoms in dermatology. Dermatological patients may complain of an itch, which is a particularly frequent occurrence in dermatology. Sensation of burning or stinging, pain. It should be borne in mind, however, that the subjective signs depend not only on the severity of disease, but also and to a greater measure on the individual nature of the patient, the reactivity of his nervous system, the type of higher nervous activity according to fun. Therefore, some patients react very painfully to manifestations of the disease, while others show restraint and have very little complaints in their pathological condition of the skin. This applies particularly to the sensation of itching, the pronounced character of which is determined not only by the type of the complaints, but sometimes to a greater measure by the patient's activity. The objective signs of an itch are multiple excoriations, secondary morphological elements, traces of scratches, grounded or free edges of the fingernails, and polished nail blades. These are objective signs of an itch. Multiple excoriations, traces of scratches, grounded or free edges of the fingernails, and polished nail blades. This is symptom typical for chronic itching dermatitis. For example, idiopathic eczema, atopic dermatitis, leaching plants. The presence of or absence of an itch is of fine diagnostic. Some dermatoses are always attended by itching. Scabies, urticaria, neurodermatitis, atopic dermatitis, leaching plants, almost all forms of eczema. In others, there is no itching, which is very mild, very mild. Psoriasis, pityriasis versicolor, pyoderma, after vulgaris. In some dermatoses, the itching is usually attended with scratches, scabies, tuberculosis. In others, there are no scratches despite the severe itching. Urticaria, itching plants. Besides, in patients with pruritic dermatitis, the itching usually intensifies or occurs in the night when the skin is warm under the blanket. This is particularly so in patients with scabies. Or next moment occurs in the night, intensifies or occurs in the night when parasympathetic part of the nervous system increases. Objective symptoms. To define properly the pathological skin process, which is manifested by morphological lesions or causing the skin infection, the dermatologist must apprise the condition of the skin over the whole body of the patient, its color, turgor, moistness, local temperature. The objective findings are judged on the basis of visual impression and touch. The ability to distinguish the lesions of the skin rash makes it possible to define the pathological process correctly and approach the diagnosis of dermatosis. In many cases, the clinical picture drawn on the skin by the eruptive lesions and the character of the arrangement allows the diagnosis to be made and treatment begun. In certain cases, additional methods of examination, including laboratory tests, have to be resorted to make it the diagnosis. The data are discussed in the special part of the textbook dealing with the separate pathological groups of the eruptions on the skin may be inflammatory or non-inflammatory. Most rashes in skin diseases are often inflammatory character, pigmented spots, tumors, trophy, hyperkeratosis, and manifestations. All lesions of skin eruptions are subdivided into primary and secondary. Primary morphological lesions. The inflammatory process have 5 classical symptoms: redness, swelling, pain, elevated temperature or heat, and impaired function. The severity of these symptoms, however, may vary depending on the degree of the inflammatory reaction, which may be acute or non-acute. In an acute inflammatory reaction, some of the classical signs of inflammation are clearly expressed. Redness of hyperemia or erythema is intensive and succulent. The swelling of the water is infection has unclear causes because of a marked exudative reaction which often leads to the formation of cavities, serum, or opium. The itching or burning and elevation of local temperature are very evident, and pain is sometimes felt. All this may result in disturbance of function. Is a non-inflammatory or chronic reaction. The symptoms of inflammation are less marked. Congestive cyanosis, brownish color of the foci of infection prevail and the foci are clearly demarcated. The infiltrative component of the inflammation conjunction with the proliferation of cell elements predominates. Such patients have no sensation of pain, burning, but itching is very severe sometimes. Primary morphological lesions, infiltrating primary morphological lesions, a spot. A spot is a circumscribed alteration in the color of the skin or mucous membrane. In most cases, it is not raised above the surface of the skin and doesn't differ from its consistency. According to the cause of the formation, vascular, including hemorrhagic, and the less rated pigmentation macula. Vascular macula are clinically manifested by a circumscribed radius of the skin as a result of dilatation of the vessels of the superficial vascular network. They are subdivided into inflammatory and non-inflammatory. An inflammatory vascular macula spot is a circumscribed area of skin radius of various size caused by external or internal oxygen. Depending on the degree of filling of the blood vessels, the macula differ in color. They may be red, rose colored, or bluish, cyanotic, or congested. A macula formed as a result of dilatation of the skin vessels and disappears when it is pressed, but reappears in the same form when the pressure is removed. This method is called diascoping. On this photo, we can see pink spots located on the trunk. These clinical symptoms typical for toxicoderma, the same symptoms typical for secondary symptoms. Or recurrent small inflammatory rose-colored spots, which may reach the size of the nail of the little finger compression, called roselle. On this photo, we can see roselle. Rosella may be symptom of syphilis, toxicoderma, and rubella, measles, scarlet fever, drug rash. The spot may be of an acute inflammatory character with a bright rose color, unclear contours, and a tendency to coalesce and disconnect, and is often attended with swelling and itching. There are also non-inflammatory spots, which are pale rose with a brownish tint. Their contours are clearly seen. There is no itching, and the spots don't coalesce. Rose-colored spots of an acute inflammatory character appear as a primary lesion in patients with the above-listed children's infections in eczema, dermatitis, pityriasis, rosella. Those of a non-inflammatory character of patients with secondary syphilis, pityriasis versicolor. If we can see large vascular spots, the size of a child's palm and larger, are called erythema. They may be swollen and irregular contours and a bright red color. They are attended with an itch and are consequent, as a rule, often acute inflammatory dilatation of vessels in patients with eczema, dermatitis, first-degree burn, erysiperosis inflammation. An emotional excitation, and the neurotic reactions, large non-inflammatory spots appear. Short-lived dilatation of the vessels of the superficial vascular network without itching, without inflammation. These spots are called erythema fugax, erythema of confusion. Erythema of confusion. Macula caused by stable non-inflammatory dilatation of the superficial skin vessels are called telangiectasia. They also disappear temporarily on pressure and reappear when removed. Telangiectasia are acquired spots which may occur independently of the component of the clinical picture of acne rosacea, erythematosis, and some other diseases. Effusion of blood into the skin may occur in increased permeability of the vascular walls, as a result of which hemorrhagic macula form, which don't disappear when they are pressed. Depending on the period of time after the effusion, these macula are red, bluish red, purple, green, yellow. The color changes with the gradual conversion of hemoglobin to hemocytidine and hematoidine. They are distributed according to size. Pinpoint hemorrhages are called petechia. Small round and usually multiple hemorrhages are known as purpura. Large linear hemorrhages diffusion of blood over a large area with irregular point is called ecchymosis. Massive hemorrhage with swelling of the skin, which is raised above the surface of the surrounding areas, is known as a hematoma. Hemorrhagic macula occur in allergic splices of the skin, hypovitaminosis C, some infectious diseases, typhus, rubella, scarlet fever, sepsis, hematological diseases, anemia. Next photo, pigmentation spots. Pigmentation spots form on areas with increased or decreased content of the pigment in the skin. They may be patches or hyperpigmentation or depigmentation. Pigmentation spots may be congenital, for example, lentigo, plasma, vitiligo pigmentation spots. Spots for hyperpigmentation include freckles, small areas of light brown or brown color which form on exposure to ultraviolet radiation or increased intensity. Small patches of, for example, hyperpigmentation spots, for example, in addition, hyperthyroidism. Small patches of depigmentation are called leukoderma. The leukoderma occurs in patients with secondary recurrent syphilis when these spots of depigmentation form against a hyperpigmented background. First appear the pigmentation spots in true leukoderma, and true leukoderma typical for secondary recurrent syphilis only. And this symptom is clinical symptom of neurosyphilis, nervous system. False leukoderma or secondary leukoderma, pseudoleukoderma, is encountered in place of former morphological lesions, usually macula disclamative, and in some dermatoses, pityriasis versicolor, psoriasis. When the surrounding healthy skin areas have been exposed to ultraviolet irradiation. Vitiligo is not areas of various sized devoid of pigment, which is attributed to neuroendocrine disorders and enzymatic dysfunction. Congenital absence of pigment in the skin with insufficient coloration of the eyebrows, eyelashes, and hair of the scalp is called albinism. And next primary morphological element of skin rash is papule. A papule is a solid, more or less hard lesion elevated above the skin surface. It resolves, leaving neither a scar nor cicatricatory. So the non-persistent trace pigmentation or depigmentation may remain. Papules which mainly occur in the epidermis are called epiderm of lead, for example, lead or one. Those found in the dermis are called dermatovenerology, for example, secondary syphilis. Papules most commonly have epidermal dermatization, regional planus, psoriasis, atopic dermatitis. Inflammatory and non-inflammatory papules are distinguished. The former much more frequent occurrences in psoriasis, eczema, secondary syphilis, Lesion planus. They are marked by inflammatory infiltration of the papillary layer of the dermis, dilatation of vessels, and circumscribed swelling. When pressed, the papule turns pale but doesn't lose its color. In non-inflammatory papules, there is proliferation of the epidermis or deposit of abnormal metabolites in the dermis, or proliferation of dermal tissue, for example, papilloma. Papules vary in size from that of a pinhead to that of a coin or maybe larger. Papules of the size of a millet seed or the head of a pea are held biliary. Of the size of a lentil pea, lenticular psoriasis, for example, secondary syphilis. Those of the size of a coin are called nubulary. Large or hypertrophic papules are mainly encountered in secondary recurrent spondyloma, for example. Confluent papules from legs to the size of child's thumb. Papules are usually strictly circumscribed, but they vary in shape. They may be spherical, oval, flat, pointed, polygonal, and their surface is smooth or wood. The consistency of papules may also vary, just as their color. On this photo, we can see papules, small papules, typical for Lesion or planus. The next morphological element of skin rash, primary morphological element, infiltrative element, is tubercle. Is an infiltrated solid skin elevation of a non-acute inflammatory character. Is often ulcerated and terminated by scar or cicatrization of cicatrical or cicatrical deformity. A result of evolution of tubercle is scar or scar atrophy. It is difficult to distinguish it from a nodule in its morphological appearance, especially in the initial development stage. Tuberculum and nodule may be similar in size, shape, surface, color, and consistency. The inflammatory cellular infiltration in tubercles spreads not only in the papillary, but mainly in the reticulate layers of the dermis, and histologically is an infections granuloma, which either ulcerated with the eventual formation of a scar or resolves leaving cicatrical atrophy. This is the main clinical distinction between a tuberculum and a nodule, which makes it possible to determine retrospectively many years after the process had determined whether the patient had, For instance, lesions of tertiary syphilis, of or zoos or lupus vulgaris. But the character of their arrangement, for example, the mosaic scars, typical for syphilis, the presence of bridges, typical for lupus vulgaris, or skin of lupus. In some cases, so tuberculum have a razor characteristic color, reddish brown, typical for tertiary syphilis, reddish yellow, typical for lupus vulgaris or skin tuberculosis, rusty brown, typical for leprosy. Tuberculosis occur on restricted areas of the skin as a rule, ulcer and loops, or they cause foaming and compact infiltration. Much less frequently they are scattered, disseminated. On this photo we can see a patient who has leprosy. Next primary morphological infiltrated element is nodule. It is large element, the size of a pea to that of a walnut, larger, and it's situated in the subcutaneous fat. The nodule may at first be not raised above the skin surface, in which case it is detected by palpation, but with growth it gradually becomes elevated. The nodules ulcerate and eventually cicatrization, scar. The consistency varies from soft, for example, tuberculosis, to firm elastic, leprosy, or dense elastic tertiary syphilis. The specific features of the nodules in some reasons permit disseminating them, especially stopoderma tuberculosis, polyphatia, pneuma, inversion syphilis, leproma, and leprosy. A result of evolution nodule is maybe scar, maybe scar atrophy and petrification, deposition of calcium salts. Exudative primary morphological elements. On this photo we can see vesicle, the primary morphological lesion of exudative character. It has a fluid contains cavity and is slightly elevated. A cavity with serous, less frequently serous contents. Coloring and flow are distinguished in vesicle. The vesicles may be situated under the horny layer, the middle of the epidermis, and between the epidermis and dermis. They may be unicamerate or sometimes multicamerate, in which case one gets the impression that the patient has at the last has. The size of a vesicle ranges from that of a pinhead to the size of a lens. The contents of the vesicle may be clear, serous, and often turn cloudy and fluid, which occurs when the vesicle transforms into a pig after. Such is the case in eczema, in the stage of exacerbation. We can see vesicles. The vesicles may occur on normal skin, but usually they have an inflammatory erythematous base. On the oral mucosa and rubbing skin surface, the vesicles rupture rapidly, leaving erosive surfaces. in place with a thicker skin, thicker pulse, they remain for longer. Vesicle either disappear without a trace or leaves a temporary pigmentation, as the case, for instance, during dermatitis. Vesicle formation is the histological picture marked by spongiosis, pathophysiological signs typical for eczema and allergic dermatitis, ballooning degeneration typical for herpes zoster chickenpox, and intracellular radiation. On this photo, we can see good vesicles, the serous exudate on the fold, on the erythema of the skin, and this symptom typical for herpes simplex infection. Next morphological elements. Papule is an exudative cavity lesion the size of the hazelnut to that of a hen's egg and large. Like the vesicle, it consists of a cavity with serous contents and a floor. A papule under the horny layer is called subfold. One is the thickness of the thick cells layer into epidermis, and the papule found between the epidermis and dermis is called subepidermis. The papula are spherical, semi-spherical, or oval, and their contents are clear, yellowish, spreadly cloudy of blood. Various amounts of leukocytes, epithelial cells are found. Papula occurring around the skin surface and of the mucous membrane structure rapidly and leave erosions with a border of scraps of the covering. Bulla occur in pemphigus vulgaris, autoimmune disease, malignant autoimmune disease, acute epidemic pemphigus neonatorum, drug dermatitis of toxicoderma. The pool usually forms against the background of an erythematous macula, so it may also be found on apparently healthy skin. For example, in patients with pemphigus vulgaris. You can see in this photo the patient with pemphigus vulgaris. Next, primary morphological elements pastule. Primary morphological exudative element skin pastule is an exudative cavity lesion containing pus. There is a considerable number of lymphocytes in exudate, which is also rich in albumin and globulin. Under the effect of the products of fetal activity of microbes, mainly Staphylococcus and Streptococcus. Pustules located in the thickness of the epidermis and marked by a tendency to form the crusts are now as indicative. Pustule is primary morphological pustule, primary morphological element typical for staphylococcus or mixed infection. When pus penetrates the follicles of the hair, the center of the pustule, in the center of the pustule, we can see osteofolliculitis. Folliculitis may be superficial, in which case the lesions don't leave any traces, or deep, with the formation of a scar. Staphylococcus is the most common causative agent of folliculitis. Eruption of deep non-follicular pustules pustules which form the dermis is called ectoderm. After it resolves and outer forms which heal the scar. But on this photo we can see inflammation of many hair follicles, and we can see clinical symptoms typical of carbon D4 or staphyloderm. Next morphological element is wheel. It is an exudative inflammatory lesion which forms as a result of the prescribed acute inflammatory edema of the papillary skin layer. It is a razor-cut position-like elevation, spherical, less frequently oval in shape, which is attended with strong itching. Wheel is skin symptom, allergic disease. A wheel is an ephemeral lesion. It usually disappears rapidly from several scores of minutes to a few hours, leaving no trace. It may be the size of a pin to that of a palm and larger. It is pale pink because dilatation of the vessels occurs simultaneously with the edema of the papilla. In them, the vessels are compressed and the wheels take a slave-like out. Wheels may form at the sides of mosquito, of other insect bites, after exposure to cold, contact with stinging metal, stone parts, sensitization of the organism to stone parts. Wheels appear on the skin in drug, food, and bacterial allergy, and may be induced by mechanical irritation of affected skin areas. Maybe a large persistent pills form in such cases after mechanical irritation of the skin. Secondary morphological lesions. You can see 10 secondary morphological lesions. These lesions develop in the process of pollution of primary morphological lesions, and they include pigmentation, macular, scales, crowns, superficial and deep fissured, excoriation, ulcers, scars, lignification, and vegetation. For example, pigmentation. Primary pigmentation are mentioned about here with shell with hyperpigmentation, consequent on increased deposit of the pigment melanin after the resolution of primary elements, papules, tuberculous, pustules, and after resolution secondary morphological elements, erosion, ulcers. Skin lesions are deposit of the blood pigment, hemosiderin of the skin. Secondary hyperpigmentation is associated with the inefficient content of melanin in separate skin areas, and is now as secondary secondary pigmentation macular changes the shape and contours of the lesions with treatment techniques. Scales of sperm are detached honey line. Maybe physiological scale of lamina of the body layer of use continuously under normal conditions. These lamina are removed by washing and rubbing of the clothes against the skin. In some pathological conditions, the formed scales are seen with the naked eye. They characterize the process of abnormal discrimination. Small and fine scales resembling low brain are called brain and shape. Such scales is termed process discrimination. For example, pediatrics vertical. Scales are among the constant objective symptoms of some dermatosis. For example, psoriasis, ichthyosis. Color. The color of scales may be white, maybe gray, yellowish, or brownish. Abnormal scaling usually occurs as a consequence of parakeratosis. Parakeratosis, histological signs, when there is no granular layer in the epidermis and the remains of the nucleus are found in the bony lamina. Knowledge of the form of inflammation and the type of scales helps in making the diagnosis of some dermatosis. For example, silver white scales, typical of psoriasis, dark scales in some forms of ichthyosis, yellow in seborrhea, loose, easily removable scales in psoriasis. For example, pityriasis rosea, pityriasis shears, is characterized by crimped and implicated scales. Next element, crust. Crust. Crust formed when a serous exudate pass of blood, sometimes with an admixture of the drugs applied to dry skin. And the other kinds of crusts are distinguished. They result from the drying of vesicles, mucosa, and pustules, the ulceration of vertex and nodules, in necrosis and purulent melting of tubes, laminated massive crusts that form of sugar. The upper part of the crust in such cases always but at the same time. The color of the crust is determined by the character of the secretions from which they formed. They are transparent or yellowish in the serous secretion, yellow or greenish yellow in purulent secretion, red or brownish in blood secretion. When the secretions are of or a mixed character, the color of the crust changes according and takes various changes. Spot, the pigmentation spots we can see, ricoderma, sparse ricoderma. Fissura. Superficial fissura maybe does not penetrate beyond the epidermis and hits without penetrates, and deep fissura forms in the epidermis, in the dermis, sometimes the involvement of the deeper tissues and leaves a scar after healing. Linear fissura defects in the skin appear when the skin loses its elasticity due to the inflammatory infiltration of skin areas that are subject to stretching. For example, the fold between the fingers, or in the region of the arms. They also form in chronic eczema, pyodermal, fungal lesions at the end of the angles of the mouth. Deep fissura may be encoded in during congenital series. They form around the nature of Next morphological elements of skin rash: excoriation. Excoriation is the skin defect resulting from scratches or some other traumatic damage. Scratching may injure not only the epidermis, but also the papillary layer of the dermis. No scars form in such cases. A deeper penetrating excoriation leaves a scar. Maybe pigmentation or depigmentation. Excoriations are objective signs of intensivity itching. The localization and shape of the excoriation sometimes help in making to the diagnosis, for example, skin or atopic dermatitis. Vegetation. Vegetation. Form in the region of persistent inflammatory causes as a result of intensified proliferation of the epidermal cell layer. The appearance of really dermatophilic, which then other characteristics. Vegetation whose surface is covered with a thickened horny layer are hard, dry, and gray. Eroded vegetation, which are a frequent when the lesion occurs or rubbed surface, are soft, pinkish red or red. They bleed easily and discharge a series of serous secretion with the development of a secondary infection. Tenderness, a band of hypericity on the territory, and seroproblem discharge period. In skin and venereal diseases, eruption may be monomorphic skin rash. Pigmentation. Or pigmentation, a thickening and hardening of the skin marked by exacerbation of its normal pattern, hyperpigmentation, dryness, and chagrin-like appearance. Lignification may be primary development as a consequence of long-term irritation of the skin by scratching, or for example, patients with atopic dermatitis, or secondary in confluence of papular lesions, for example, chronic eczema, lesion of plants. In lignification, the cell layer of the epidermis is hypertrophic. On this photo, we can see ichthyosis. Evolution of morphological lesions. We can see on this photo what we can see after solution of spot infected squama and pigmentation. After resolution, exudative morphological element, you can see erosion, crust, squama, and pigmentation. A result of evolution and deep ulcer, crust, squama, and scalp. Disappears rapidly without any traces, or may become squama. Eruption may be monomorphic and polymorphic. Monomorphic eruption, seen type of primary morphological lesions, for example, papule, psoriasis, and warts. While these monomorphic dermatoses are distinguished among which are psoriasis, urticaria, papulus vulgaris, folliculosis, condition is called true polymorphism. The group of dermatoses in which true polymorphism is encountered includes eczema, leprosy, dermatitis, herpetiformis, polymorphic exudative erythema, secondary periodontitis. These are cases of polymorphic disease. And we can see on this photo small diseases, serous exudative, and papules. Recognition of a monomorphic or polymorphic eruption or pulse polymorphism makes the diagnosis easier. It's all. Thank you for attention. Goodbye.
Goodbye.